Welcome to the Shockwave Therapy Podcast. My name is James Woolidge, osteopath and clinical director at the Abbeyfields Clinic in Suffolk. We will be trying to demystify the concept of shockwave treatment whilst bringing together experts in their field to discuss the latest research. If you are deciding on whether to add this modality into your clinic or just improve the way you deliver it, then we hope this is the podcast for you. Welcome to episode 3. We're joined today by Andrew Davidson, a Senior Physiotherapist at the Homerton Hospital in London. He is involved in research, education as far as complex pain conditions are concerned and persistent tendinopathies. With his role in the NHS, it would be really interesting today to pick his brains as to how he sees shockwave fitting into a clinic environment where they have multiple choices of treatment and where he is going to be able to hopefully shed some light on the choices that are involved in deciding whether shockwave should be used or not, and also in a broader framework of a biopsychosocial model. His particular interests are in dealing with those aspects as well, and I know that he's got a great interest in sleep and the science of sleep. So it'll be a slightly broader topic today, but hopefully there will be some really good information coming out of this. So welcome, Andrew. Thanks for joining us today.
Thank you so much.
We're going to make this as simple today, I think, as we can, because the previous two podcasts were challenging in detail, which I think some people like. But I really wanted to look at today at being something about your experiences in an NHS setting, where you have the advantage, I think, of using a lot more tech than we do in private practice, but also because you've got a number of choices of treatment at your disposal. It's really about trying to get you to sort of get some sort of information across to us about what the decisions are, about when to use it and in what population groups and so forth. So can you start us off on that about your role? Just give us a quick summary of your role in the NHS as it is at Homerton Hospital, will you, and how you use shockwave?
Absolutely, yeah. So I work as a senior physio in the Homerton, and I've pretty much always been there since I qualified back in 2011. Within the first year of me being there, my consultant physio at the time had a colleague who'd been using, it was a podiatry colleague, had been using radio shockwave for plantar fasciitis. And back then it was not particularly popular. As far as we were aware, there were maybe a few NHS services in the country that had access to the machine, but it was a very murky, muddy way. It was not really funded. It wasn't really paid for. It wasn't really used very well. So we put a business case together for the hospital, justified it based on the research that was available, that we'd be able to make back the money and it would all be excellent and nothing to worry about. We'll run it simply. So we got the first machine. We had, I think, half an hour training from the manufacturer on how to use it. And it was just basically figure it out, see what you can do. So I think the first little chunk of time was a little bit of trial and error. But when it comes to shockwave, the error is very low risk. So we didn't actually do any harm, but it took us a while to figure out how to optimize the location, the setting, the pathways. And I think now we've got a really nice structure going and it's yielding fantastic results. And I can talk a little bit about what kind of pathway was set up to date, if you want.
Well, that'd be great. So what the groups that get triaged through to you, what kind of groups are they in and how long have they had the problems for?
Yeah, so what I do like is, as we're based in Hackney, actually it is quite a tricky demographic we work with. We're the second most deprived local authority in the UK, even despite the Olympics and all the money that sort of flushed through. About 27% of the population, which is 270,000 people, are struggling and suffering with chronic pain or persistent pain. And as a result, we have a really, really good pain service that's been designed. And I used to work there for a few years before I moved over into a sort of more sports setting that I'm in now. But what we found is that we could find a role for the machine within a persistent pain population in order to basically try and reduce the need for further invasive treatments, including injections, medications, or surgeries.
Right.
But at the same time, because it is a simple device and it has a couple of really nice evidence-based effects that we are happy to say that we can definitely do with good confidence, and then maybe a couple of secondary effects, as I call them, that maybe not as research-based, but at the same time are sort of handy side effects that will work in a more sporting population as well. So we don't really triage we triage everyone down the same pathway,
Yeah.
and try to make the treatments they get as they go along as bespoke as possible. But ultimately, when it comes to Shockwave, we get everything from the chronic 20-year histories of usually plantar fasciitis, to be honest. It is one of the bigger ones.
Yeah.
But you will get your gluteal tendinopathies, your rotator cuff dysfunctions, and your tennis elbows just as often in that persistent population. And then with the sporting one, we have a little bit of a higher level ones we work with. Sometimes they are Achilles tendons in semi-professional football players is quite a big one, as well
Sure.
as basketball players with their patellar tendinopathies. A couple of insertional hamstrings, proximal hamstrings, which have been really interesting.
Yeah. How on that? That's an interesting note. If we can just pick up on that, because that.
Yeah,
how's your success rate with the high hamstrings?
So I probably don't have a particularly large sample size right now. I think I could confidently say about 25 or 30 or so people, and I would confidently say 2/3 of those have got back to a sporting role,
Right.
And a third of them are so-called non-responders.
And you use radial only, or have you got some focus there as well?
So this is an interesting point when it comes to private and the NHS, because you're absolutely right in that in the NHS we have access to some nice kit, but that's mainly related to imaging, to sort of having consultants and specialists that we can work with.
Yeah.
So we have a bit more of an MDT around every patient that we treat. But we have an absolute astronomical amount of red tape to go through before we can get anything approved in the damn NHS.
Right, okay.
One of them being a focused Shockwave device. So I've done a lot of work over the last few years to try and gently drop hints and influence the various powers that be.
Yeah, sure.
That we are absolutely wasting our time by not having this device here. And to be honest, what it often comes down to is you need to convince the consultants and the surgeons.
Yeah.
More so than the rehab staff, because rehab staff are more often than not very keen on just using non-invasive interventions for patients. They know the risks that come with more invasive treatments, but the consultants, they've spent a lot of time getting where they are, and you got to look after them. They're very highly professional, but at the same time, they don't often know as much about these devices, and unless you get them sitting down in a room around a table for 45 minutes, you're not really going to really get the message across. So we're trying to find a way that will make it kind of useful for them as well.
Okay.
And the key way I'm doing that right now is trying to highlight that there are probably a few people on their waiting list that are not going to be very good candidates for surgery. They're not really keen on doing surgery with these people either. Yeah. They want people that are going to have good outcomes. So we can probably take the ones that are not going to respond and treat them with these machines instead.
And that's always the real thing that I've seen with Shockwave, is that that if they've tried really conservative approaches first, then why wouldn't the question really is reversed? Why wouldn't you try Shockwave before you do something invasive? And the evidence, people can always pick holes in some parts of the evidence for some conditions, but when you're looking at someone that's tried everything else, what else are their options? And there just aren't any for a chronic tendinopathy, really, apart from someone injecting it if they're brave, or debriding it, or some other such thing, which the evidence is pretty poor. So I always feel like I'm on sure ground by answering that in the same way every time, saying, well, why wouldn't you want to do that before you try anything else?
I'd agree with that, and I think at the same time with something like if we take a radial one on its own, the radial device, we know the side effects and risks are so low. Having done a couple of pieces of research myself and been fortunate enough to publish one piece of material, that took 2 years from start to finish to get through. It took me over 7 months to get both local and national ethics approval for the study. It took me another sort of 8 to 10 months to get the patients treated, and then we followed them up for a year after their treatment, because we wanted a longer term follow-up. That was one of the critiques of the literature at the time, that all the follow-ups were 2 to 3 months ahead, and it was good for pain, but we wanted to see return to sport. We wanted to see how did they stack up versus conservative management a year later. And when I finally submitted it, and I'd written it, and I put all my time and effort, most of it unpaid labour. I got a little bit of funding from the local R&D department, but that was mainly just to deliver the treatment in a clinic after hours. They rejected it first time I submitted it, and I had to spend another couple of months rewriting it and send it back in again. So I don't think we're going to see a paper for every single condition we could possibly treat this for, A, because it's so difficult to do, and B, because I think it comes down to this absolute hell-bent desire to have a specific treatment setting for one condition with one patient.
Yes.
It doesn't work like that. We're having an influence on someone's pain system, someone's experience of pain.
Yes,
and that
yes,
is an
yes.
almost entirely subjective experience that is influenced by so many factors that it's ridiculous to think that you have to treat someone at this condition at 1.2 or 1.4 or 1.6 bars of pressure. It's not going to be like that, and you won't get any good results if you try and define a whole paper that way.
Yeah.
And anyway, we have 3,000 articles on this thing. It's been researched to death. I mean, good lord. If you need to research something 3,000 times, you're either doing all of the research wrong, or it's just not working the way you think it's going to work. So there's plenty of good systematic reviews to justify that it is a useful tool more than half of the time for chronic tendinopathies, and it can return to sport quicker, and it's non-invasive, and it's safe. Done. That's all we need to do. We don't do that with injections. You give me 5 papers on injection therapy, please. I'll wait.
Right. Hey. Off the soapbox. So I know that you and I have had chats about this before, and I've tried to tackle it with the previous 2 podcasts about the fact that people have begun to see this as they do with new devices as the be-all and wonderful panacea. You know, you plug it in, you press on the sore spot, and you have to do no more else. But you and I have had discussions about the fact that as a part of a biopsychosocial management of that patient, because as we know, pain is way more complex than just a nerve fiber that we no longer call a pain fiber traveling up to the brain, so I'm in pain.
Yeah.
Exactly. I when I see patients in clinic, they often share a graded loading program, and we give them advice on sleep and reassuring them, managing to remove their threat away from the fact their tendons are going to rupture. So I'm assuming you speaking the same language. Can you just emphasize your thoughts on the fact that we shouldn't be seeing it as a one-hit wonder for everyone's problems?
Absolutely, you've hit it on the nail there. In particular, with the sleep element, which I know I harp on about a lot, but I really cannot hammer home how important sleep really is to recovery, and I can't believe it's not really, even in the NHS, considered a particularly important element of focus. With the pain aspect and the biopsychosocial aspect of this, I think oftentimes it comes down to, or the reluctance to adopt these models simply come down to a little bit of fear and worry and anxiety from the practitioners who don't feel they have the competency to take that approach. They don't feel comfortable talking about someone's mental health. They don't feel comfortable talking about how they're doing at home. What's their financial situation like? Are you self-employed and you can't work because of this tendon? Well, if you're walking around with an incredible amount of financial stress, this graded loading program is probably not going to be sufficient, or Shockwave on its own is not really going to tackle that. So I'm not here to fix your financial worries. I'm not here to fix your sleep, but I'm here to provide education, advice, and reassurance. If you understand something, there was a great little paper, I just have a copy of it here, on expectations and persistent pain being one of the biggest predictors for recovery. If you have if you have an expectation that you're not going to be better, which is largely what the Start Back tool for lower back pain was about.
Yeah, sure, it was.
If you're going to get better, you can kind of throw everything you want at them. There's a good chance they're not going to get better.
Yes.
And the stress, I think, comes down to the time limitation we sometimes have in the NHS, where a large group of these patients are seen. But at the same time, when you're in the private, then you don't necessarily have the teaching, the in-service training, and then the team alongside you to have these discussions and debates with.
Yeah.
So ultimately, I think the best way forward is probably a combination between the 2 approaches we could take. The freedom in the private market to kind of explore and use devices that have lots and plenty of evidence without having to troll through red tape to get it through.
Yeah, absolutely.
And the clinical support you get through the NHS.
Yeah.
So I would insist when someone comes through with a persistent tendinopathy, I don't view it as a tendon problem initially. We do a thorough and a proper biomechanical assessment of the function of their tissues and their capacity. So I love this load capacity model of what are you doing right now and what are you capable of doing. So I need to know what they're doing during the day, not just what their sporting aspirations are. I want to run 10K and I can't do that right now. Well, that's not that interesting to me. What you can't do. So how long does it take you to commute to work? And are you sitting down or standing up when you do so? And how long do you stand or sit for when you're at work? And how many hours is that? And then when you come home, do you sit down all day, and then do you sleep for 8 hours? So basically we have 18 to 20 hours of inactivity during the day. Well, that could be the first thing that we try and do in terms of increasing loads. It doesn't even have to be exercise, or it could be the opposite of reducing that load. So it takes time to develop these skills, but the research and the training and the tools, they're all out there. I think it's just that people are a bit worried that we're going to lose that kind of quintessential skill set we were given in university, which without being too harsh to these people, I think it comes down to a bit of an ego trip where you want to feel like you're the person who has your hands, something in your body, in your hands to fix someone, It's like
I think
a bit of a power thing.
And I think that actually, there is an element of threat, professional threat that, surely I've got the skills, surely it is this tendon I can rub or whatever else. But actually, I think people often, when you speak to them about, what dealing with it in a BPS sort of framework, it is not that complicated. And actually, most practitioners are doing those things where they're listening, they're caring, they're reassuring, and they just need to accept that they're almost there with what they're doing anyway. It's just making sure that in their on reflecting on how they manage the patient, it's a knowledge that actually probably at least half of that patient's benefit has come about through your reassurance, listening, caring, rather than just the magic, Shockwave machine, which we're going to go off tack here too much. But I think going back to what you said a minute ago about I think some elements of the reassurance about expectations. I listen quite a lot to Lorimer Mosley, and he talks about this idea of threat. And I think when I see a lot of runners here with Achilles problems, and if you sort of simply state to that patient that they can still run as long as it's within a certain amount of pain, and I like Tom Goom's work on this, where he's done some nice infographics about it's okay to to 5 out of 10 pain and so forth, and you give them that confidence that they're not also going to likely rupture that tendon. So the data doesn't suggest if you've got a tendinopathy you're more likely to rupture. And you can see the weight just lifting from the shoulders, that they know they can go for a run, it can hurt a bit, and it's okay. And that's probably more powerful for that 2 minutes of conversation than the best Shockwave machine that exists. But
100%,
it's putting it all together to say, look, actually after 3 sessions of Shockwave, you've had all this information, you're reassured, you're happy running again, and you felt 75% better. I'm quite happy that out of that 75%, 38.5 or whatever is coming from my reassurance. I don't need it to come from my machine necessarily, but the two together work well.
Exactly. I like to draw this stuff to patients, but because I do preach a little bit to patients, and I've caught myself recently trying to not be so, I think they call it a didactic approach, where you're just telling and telling and telling. So
I fall into that category sometimes.
Well, I think it's benign because it comes from a certain level of passion and enthusiasm for what we're talking about, and therefore it can be quite tempting just to be like, look, I've got all this great information, you should have it. But at the same time, there are certain things that it's just information and knowledge that they should have, and you can turn it into a discussion. But I'll draw and I'll write this stuff down, and I'll put them into like a pain tree, for example, where I'll put pain in the middle, and I'll start drawing a line over to how that can influence certain parts of your day. And that could be your sleep, which then affects your immune capacity and your nervous system health, which then can increase your pain further. So you've got one loop, and then you just keep creating these loops about deconditioning and mental health and social life. And then they start to see for themselves how complicated this picture actually is. And I say, we can't just take away the bit in the middle. Just go take painkillers if you want to do that. Like, that won't influence any of these other factors. So I'll draw a little Shockwave machine, and I'll show the different bits of that tree that can influence, and then I'll put some exercise next to it and show how that can influence other bits, and then I'll put mental health, and then we start to see that they start to get on board with how is my mindfulness or my positivity going to influence this, but how is Shockwave going to play in? And then they don't end up putting all of their eggs into the one basket of Shockwave, because I think the biggest thing we struggle with Shockwave in particular is that it can have a really powerful analgesic or pain relieving effect in a very short term. And if you have been struggling with pain for a long time, that is an absolute godsend. That is so amazing. So when that effect naturally wears off, because it is a transient effect 3 days later, you associate the return of pain with the return of trauma or damage or harm. And if that isn't explained beforehand, then you will end up treating them with this forever. They will not ultimately achieve the goal they're looking for in the long term. And that's one thing I've explored now with I'm treating a group of footballers with adductor tendinopathy. We're trying to do a little mini study on that, with groin strains and osteitis pubis, and I can really see the difference now. We're trying to find out with predictive markers for what was the markers that were more likely to suggest if someone got better or not, and they were all related to their their belief and expectation, plus adherence to training while they were undergoing the Shockwave. So
Sure.
those that really thought and hoped that it would take their pain away and fix them are just not the ones that are getting better.
That's interesting, specifically in that subgroup. That is interesting, isn't it? But that again, it probably comes back to that idea that Lorimer Moseley talks about, is that level of threat. That if you have a particular condition that is threatening your potential career or the thing that you enjoy most, then he will say there's good evidence to say that that affects level of pain, and it also affects the chronicity or the potential to become chronic with that condition.
100%. If you look at rupture rates and tendinopathy, those that are more likely to rupture a tendon do not have pain preceding that rupture. So
yes.
Pain is not the thing that's associated with rupture. And that's the first thing I'll tell, in particular the Achilles ones, who
yes.
Also the ones who've already had a ruptured Achilles. We are treating a very large group of Achilles ruptures conservatively now. Anyone who's basically over 35, to be honest, not to be too harsh on when you're a little bit older, but they have mortgages and houses and work, and they need to do around 200 minutes of rehab a week if they're going to have this surgically managed, and their re-rupture rates are a little bit higher with the risk. The re-rupture rates are probably the same, but there was a higher risk of other complications once you've had surgery.
Right.
So we give them this data to show them that you've made the right choice by going conservative. Like you can decide, but you need to own the decision that you make at the end of it. You have to make it your decision and not feel like this was something you were almost influenced or forced to do. And once you're at that sort of headspace with your rehab, at the end of it, the biggest predictor for whether or not they return to sport was a psychological fear of re-injury, and not the actual health or strength of the tendon itself. And it's the same with ACL injuries as well. That's the biggest predictor.
Right.
So
I
think what's interesting, we have an incredibly good ACL rehabilitation platform at our hospital for surgical patients. We follow them up for almost a full year, from 9 months to a year, with weekly and then bi-weekly sessions, and we don't have the same thing for the conservatively managed ones. So again, linking all of this back to Shockwave, we know we can have some incredibly powerful effects on a cellular level with the different settings we use with our Shockwave machine. But the key factor for every single element of that is the graded loading program.
Yes.
But we don't always have as much of either a confidence or a competency when it comes to return to sports or higher level populations. We kind of drop off a little bit, I think, with the higher level stuff. And that is then a more of a biomechanical understanding as well. So I think what people fear a little bit when it comes to the biopsychosocial model is that we don't care about loading. We don't care about strength and conditioning. Like, we don't care about biomechanics. Like, of course we do. Absolutely.
And of course, the irony is that is why it's called the biopsychosocial. And people people forget that at its very heart, that is what it's always about. And it seems to get lost there. But let's try and bring it back. One of the first things I was thinking about in terms of questions was, I know when you first started helping me with my journey into Shockwave, you were talking about some of the results of the scanning that you were doing, the ultrasound scanning, high level stuff. And that people always, there's always going to be people that say, does it really change tendons? What happens in the tendons, and this and the other? Can you give us a bit of feedback on some of the things that you've seen on the scanning side of things in terms of use of Shockwave?
Yeah, so with I think there's probably two factors that I find interesting when it comes to imaging, and I always stress that it is not essential. I do not think it has to be an absolutely essential defined part of this pathway. I think we're just lucky that we have a lot of people who have sonography as a bit of a special interest field in my clinic, but I would not really be crying if I didn't have that. Ultimately, the one thing I'm interested in is the field, this neovascularity sort of topic. The growth of neovessels inside of a tendon, is this really associated with a lower risk of return to sport or a higher risk of chronicity? The best description I had of it was actually a colleague of mine he is a physio, he's an anatomist, so he does dissections at St. George's University. He's a bit of a morbid guy, but he managed to, I don't know how he did that, because he wasn't really qualified to do so, but he blagged his way into St. George's, and he's a lovely
Let's hope
guy.
He listens to this.
I'm sure he will. Get the scalpel out, and then he'll be told, I need 4 ankles done by Monday, and he just spend his weekend, slicing, dicing these tendons. So incredibly detailed understanding of anatomy and biomechanics, and he'll talk of a tendon as this really tight compressive structure that's under a lot of load. Think of the Achilles, for example, constantly under a huge amount of spring and tension, and as it elongates, it compresses, it tightens, and it squishes everything that's inside of it. So on a very, very basic level, where we have the presence of a neovessel or vascularity, there is also a sensory presence. It is not supposed to be that from an anatomical point of view, it doesn't seem to do anything. And as you squish it and squeeze it, you have a sensory response as a result of that.
Yes.
And wherever we have senses or sensory responses, they can become hypersensitized. So I think more of an association, you could say, where there is a presence of neovessels, that could be associated with an increasing risk of hypersensitivity. So that I'm comfortable saying.
Yes.
And then on the side of that, we have seen that the Shockwave in the short term was powerful enough at a higher level to break down, for lack of a better word, break down the presence of these vessels when we rescanned them directly after a session that we'd done. So we had to try and control for a few factors when we had, if you get someone to run for 1 or 2 minutes, you will increase the sort of visual effect of the vascularity on the scan. So we had to make sure everyone had kind of been still and not done anything. Was
this just using really good ultrasonography, or were you using a UTC or whatever it's called?
Yeah, no. So I would love to get my hands on a UTC machine. I know there's one in London,
right?
And there's a colleague of mine who has it in his clinic. To be honest, I don't think he uses it very much, but he does have one, and that would be some pretty interesting stuff. But it's not the most practical machine. You'd have to do it a little bit more like an MRI, where you put them in and they go in for a full day. Yeah. So it takes away a little bit of the sort of usability of an ultrasound. But yeah, we have some really nice ultrasound machines. I will say that they were donated to the hospital after the Olympics. And sort of 150 grand, incredibly sort of clear and fancy, beautiful images.
Yeah.
And we saw.
So you saw those definitive changes happen straight after Shockwave. So it is definitely creating a mechanical change in the tissues. Is what I'm looking for there.
Yeah. And that's where how I've sort of delivered my teaching of Shockwave has changed a little bit over the years. One thing I've adapted over the last couple of years is this idea that if I think about it as having 3 categories of changes, that fits roughly how the settings of the machine work, and it's easier to kind of picture it in your head.
Right.
With the I call it the pain relieving or the analgesic effects being the first category, where there is a low bar of pressure, a low power, and a high frequency. Yeah. That does not penetrate very deeply. It mainly sits around the surface of the tendon area. It has mainly an effect on the nervous system, potentially using a pain gate theory based approach to hyperstimulation anesthesia or some pain relief from there. So if that's all someone can handle, you can feel justified in just doing a low dose treatment for the first session, knowing that whilst you might not induce a lot of cellular changes to the tendon, you have likely changed their perception and experience of pain alongside all that other biopsychosocial stuff with a bit of loading. They come in next week, and hopefully we're in a better state to then try again.
Sure.
The second category I call the regenerative phase, where we're arbitrarily between 1.8 to 2.5 bar. It's a little bit hard to put exact numbers on them, but we are now penetrating a little bit deeper. The frequency is around 10. We are deep enough now to hit the tendon itself, and with just enough power to start to induce some changes on the inside of that tendon, potentially stimulating the growth of a couple of tenocytes, which we hope to then turn into tendon fibrils through loading. That's that pro-collagen synthesis sort of element of a tendinopathy.
Yeah, lovely.
And then maybe enough power at the 2.5 mark to start breaking down some vessels. But that really, as far as I'm aware, start to happen at a little bit of a higher dose, which is then the degenerative phase. And anything above 2.5 up to 3.5 with around 8 to 10, again, just a decent frequency. But that power is what we're looking for like calcifications or big neovessels or big thick harder complex tendons. We really want to try and break them down. So it's not clear black and white, but that's the 3 sort of phases, and they're sort of fluid. That's how I picture them. So I think that helps.
That's pretty well. Yeah, it's pretty good that you've only got 3, because you can get into 8 and 10 and start talking stem cells and other sorts of complicated things.
Well,
But
exactly.
I think that in terms of communicating to patients, which is where probably the most clinical efficacy is trying to get something that they can go away with in their mind is actually, you know, the most day-to-day useful, isn't it? I think those 3 ways of saying it are probably quite helpful. So what in terms of your NHS clinic, what guides you in terms of treatment number, and gap between treatment and so forth? Let's just talk through what you do with that at the Homerton.
Yeah, so the Homerton clinic, as it runs at the moment, has a little bit of say bureaucracy around how the clinic is run, because they want a certain efficacy as well. So we know you need to have at least 3 sessions to be effective, so they have defined it as having 3. So everyone just comes around for a round of 3,
right.
And because it's booked in blocks of 3, that means that it's easier for the admin staff and the booking staff to just book people up for, you know, a couple of months ahead. They've got these rounds of 3 just constantly running.
And are they with a week apart?
Yes, so for convenience, they have set them 7 days apart.
Right.
What we've done, basically, because I've been there for enough time now, is that if there's anyone particularly complex or anyone on my caseload, I will see them personally. I won't refer them into the Shockwave clinic, and that way I keep the waiting list down a little bit. And I personally do 4 sessions. I've added an extra one towards the end. Privately, I open up to have 5, but I wouldn't really offer more than 5. That's a little bit of a personal preference, but also because I can't really justify from the evidence base that there's any higher efficacy after 5 sessions, and also there potentially is some sort of ceiling effect where we're inducing harm and reliance as opposed to some positive effects. And also we need to start properly loading this tendon at some point, so you don't want to just shock it forever.
Yes.
So 4 I have defined, because I know 3 is the bare minimum, and so I think having 1 extra just allows us for a little bit of extra input. I also do a slightly higher volume. So in the clinic, they will do about 2,500 to 3,000 impulses.
Yeah.
I've started doing 4,000, and that is also because I spend a little bit more time at the very start of the treatment, essentially getting them used to the sound and the feel of the device. So I don't really count the first 500 or 1,000 as having any particular.
And you'd set that high frequency, low bar just to get them used to it, would you?
But with everyone who comes through, I have a 1.0 is the number I start at.
Right.
I'll put it to 4,000, and I'll set it around 12, maybe 12, 14 to start with. So yeah, it comes out quite fast. But what I'll do before I start it is I turn the machine on, I put it in the palm of my hand while they're watching. And again, there's something about that little visual input. Like if this guy's crazy enough to put this thing on his hand, It can't be that scary. And then, you gently start to put that onto the skin, not directly on top of the symptomatic tissue.
Sure.
I treat a little bit around the periphery and then work in towards the tender part afterwards.
Yeah.
As they come through, if they can tolerate it, the second session even, they already know what to expect. So I start maybe a little bit higher next time, and I don't spend so much time at the lower levels. But I 4,000 and at least 4 sessions. That's my current particular approach.
I mean, when I do some of the teaching as well, the one thing I noticed that I was sort of a bit different on, and not sure why, but I mean probably because I'm not sure why, to be honest, but I mean, I treat all my plantar fasciitis. Everything that I treat, I always try and make sure that I can see the patient face to face. I can't remember the last time I put a patient on their front. People are always a bit sort of freaked by that. And so you can get to every bit of tissue that you need, whilst also having a sort of eye-to-eye contact with the patient. I think there's a reassurance in the fact that they can see what's happening, and it's not they're just on their front and they've got their foot in the air and they've put this foreign machine that makes a hell of a noise on their tissues. I think for all those reasons we talked about with BPS earlier, I always struck me as being obvious that you'd want to do that, but there's always a position you can get them into.
And I do exactly the same. That's how I'm teaching at the moment too. And I think yes, there's a reliance. I also maintain a conversation with them while we're talking.
Yeah.
Just that tiny little bit distraction. But I'll be talking about the tendon and about the effects that we're doing, about their loading, and if there's anything in their particular case or history that I think we need to maybe address, like providing some education on sleep or whatever. But just kind of, again, it's that reassurance and it keeps it going. And I also find with a couple of ones who are just naturally a little bit anxious, or you can't quite get them fully relaxed or reassured, I'll get them to put some headphones in, listen to some music, and just you just let me do my thing, you just relax. I'll do my thing back here. You give me a shout if anything happens. And so they can see the device as well. I know not everyone has a device with a screen attached to it. The screen has minimal clinical value, to be honest.
Yes,
but
indeed,
if you happen to have bought one with the screen, then I'll show them the screen so they can look at that and see the numbers go up, and they can kind of see when it's about to finish. And so you use the tools you have available to you, but I think the 2 most powerful ones are comfortable position, definitely. And in terms of how much pain they should experience during the treatment, that's another huge field that we always talk about. I have a good couple of people that I've done some training with who's bought the machine, they've used it for a while, and then they've asked for training because it's not quite going well. And there's this I don't know where this belief really came from, that you're supposed to hammer it home and kind of the more painful the better. There's a lot of people out there who are using the machine that way. I think maybe it might be because there was evidence to say, the higher the energy level, the higher the treatment effects. But
and now it seems to be, I've been reading that it seems to be coming back down from that, doesn't it?
Well, which would make complete sense, because to use someone's subjective pain experience as a guide for how much power you should put this machine through, when you probably haven't addressed any of the factors in place to determine how hard or how high that pain level is going to be before you start. I had a guy who I went to a BMI hospital, and just as I came in to do the teaching into a room, I saw someone came limping out of a room, and a consultant who squeamishly quickly shut the door. And he treated this lady's plantar fasciitis. She was in tears. She was limping out the room. And he was on 5 bars of pressure with this thing, which is technically intended for horses, if I'm not entirely mistaken. It's not really meant for mammals. It's kind of meant to be rammed home with race horses with tennis ball calcifications. But anyway, you get the idea. If she genuinely believes that would make her better, and she walks off and loads it well and sleeps good, and God bless her, by all means, you're not going to rupture anything. But yeah, my personal effect is, it's a little bit like you said. If they want me to put a number on it, sure, it'll be around the 4 or 5 mark. But I use words like I say soft or hard pain words. Like if it's achy and it's sore and it's tender, but it eases off, we have a 24-hour load response to tendinopathy. If 24 hours later it gets better and goes away, then you haven't done any problems. If you wake up 24 hours later and it's really painful, then it's unlikely to be the shockwave. You've probably loaded it a little bit too high in the period after you've had the shockwave, because you had a nice pain relieving effect.
Yeah, I always warn patients not to get too carried away with that.
Yeah, just take it easy for 24 hours. Wake up tomorrow morning and tell me how you feel.
Yeah.
And then about a week later, and I'll do between sort of 4 and 7 days for my follow-ups. If I'm seeing them in my clinic, I don't always have to wait 7 full days. I can, if it's convenient for them, I can see them a little bit sooner. But I don't like going much longer than 7, because there does seem to be some sort of drop-off in terms of those clinical effects.
Yeah. Okay. Great. All right. Well, that's. I'm looking at the list of things we sort of said we'd discuss, and that's pretty much tackled all of them, particularly the BPS and the sleep stuff. I think we could probably definitely spend more time going through another podcast in the future about some of the graded loading stuff and sleep, and I know that we could probably get really boring about neurogenic inflammation and hormonal effects on tendons.
Oh yeah.
So why don't we'll reconvene at some point after I've got another few podcasts done. But thanks very much for today. As always, I say this to everyone, and I'm completely genuine. I always learn everything. I always learn something myself every time I talk to one of you guys about this stuff. So I'm going to re-listen to this afternoon. But thanks for your time, Andrew, and we'll speak again soon.
My pleasure. Get in touch whenever you want. Nice
Cheers. Thank you. Bye.
See ya. All right. Bye.